I may help to the start of the discussion, and one question is about levodopa responsiveness. Could levodopa motor symptoms? Could levodopa responsiveness remain one of the major diagnosis criteria for PD, or can we consider on pathological aspects that some patients cannot respond to levodopa but still have the pathological hallmark of PD?
Well, I think the answer is yes, and indeed the Queen Square Brain Bank itself has identified that there are occasional, they're very rare, brains with typical Parkinson's disease pathology who did not respond to levodopa even at the very high doses for prolonged periods. So there are occasional cases, and that may be for specific pharmacological reasons why those individuals didn't respond. But I think the use of levodopa responsiveness in terms of, thank you, in terms of the definition, of course this is only applied after the clinical diagnosis is made. And the use of levodopa as a test to confirm the diagnosis is not often used by people. It's the clinical features that define the disease. And the patient, if they do not respond well to high doses for prolonged periods of levodopa, I think you have to reconsider the diagnosis. You may have got that wrong. But just to emphasize that the audit of the Queen Square Brain Bank criteria by pathology proved that movement disorder specialists are right almost 99% of the time if they apply the criteria correctly.
Thank you. Professor Olanov.
So first I would like to congratulate the two debaters, is that the term, debater, on a challenging and excellent debate. I also was one of the signers of that paper. And after having heard Professor Shapiro's talk, I'm withdrawing my name, I'm taking it off. I congratulate you, Tony, because you took what seemed to be an indefensible position and you actually made very cogent arguments. And in fact, I think when you think of it, and even though I know you know, the joy of these meetings is we take positions, but we all sort of stand somewhere in between. But the point of the matter is, and I think this is the main point you're making, is do we want to throw away everything we have when we're getting it right 99% of the time using the current criteria? And that's probably more than we do almost any other disease we have. On the other hand, Amos, what I'd like you to respond to is, I completely agree with you. There are genetic issues. There are the classic motor features. There are the pathology variabilities that are not addressed by the current criteria. The question, which is very philosophical, I don't know that there's an answer, and we wrestle with it when we write on these papers, is what does it mean to change the definition? Every time you add a little bit more knowledge, which we continuously gain, does that really mean we've changed the definition or that our knowledge is just expanding a little? And I wondered if you could comment on that.
And just before Amos does, may I draw people's attention to the title of the article that was published in Lancet Neurology. It was the research criteria as opposed to the clinical criteria of Parkinson's disease.
So there are no research criteria that have existed. I mean, the brain bank criteria are clinical criteria. They are not research criteria. So you don't have to rechange, but you have to formulate. And I agree with Warren Olano that it's a task. Before I return to what Warren said, this misconception of 99% agreement, I think this is not what is written in the paper. And remember, that the pathologists were not blinded to the diagnosis, and that the clinical diagnosis that were used in the comparison was the diagnosis, the last diagnosis pre-mortem, not the initial diagnosis. in the initial day. And we know that when we see patients, we follow up patients for 5 or 10 or 20 years, we sometimes change our mind. Maybe not in Queen Square, maybe not in London, but many others of us, think that maybe we're changing our mind. So the question is, what do we do? What do we do, and what do we do with the definition? And I hinted it. I said that there may not be a single satisfying diagnostic criteria. It may be different for clinical purposes and for experimental studies, for drug studies, for patients who are at the initial stage of disease when we want to start to study a new treatment. For social planning, each of these will have to have an agreed upon, updated clinical criteria to be used. But they are not the same. Sometimes we can supplement them with molecular data or genetic data. Sometimes this is not required.
That's a further question.
Can you please identify yourself?
Hi, Stu Isaacson, South Florida, another big place where LRRK2 is an epidemic. And we're really seeing a Jewish genetic disease, I think, down there. So the question is posed, if an Ashkenazi Jewish patient with LRRK2 positive has a less than 5 percentile upset, REM sleep behavior disorder, lifelong constipation, and mild orthostatic hypotension, does that patient have Parkinson's disease? And if they went ahead and had a DAT scan from their local doc, and that was abnormal, showing striatal dopaminergic degeneration, is that Parkinson's disease?
Well, it's Parkinson's disease by any other criteria. So if they have dopamine deficiency by SPECT, if we see evidence of that, if they have fulfilled even one criterion, I would say, had we had a disease-modifying agent, this is a time when it should have started. We should not wait for the second thing. We should not even, so if they have only RSBD, REM-sleep behavioral disorder, and olfactory dysfunction. Although, as has been mentioned by Professor Shapiro, we don't know the natural history of this. We don't know what is the prediction, so it depends. It depends what are the options to be used. So if we find that, let's say, calcium channel blockers are helpful and the patient is hypertensive, then yes, let's put them on L-type L-channel blockers. If we think or if we find, as somebody has suggested, that maybe statins are important or other anti-inflammatory agents are important, maybe we should put them on that. If we can convince them to drink coffee, that's very good. To be involved in physical exercise, yes. I would not go as far as suggesting to them to start smoking. But again, these are the options. And of course, if we restrict ourselves to the full definition, then of course we cannot implement that. So we have to modify it according to the needs. And each need may require a slightly different definition.
Okay, thank you very much.